Hi, everyone, and welcome back to another episode of Public Health Career Conversations. I am very pleased to have with me today Dr. Saqif Mustafa, who is a specialty registrar in public health medicine and based in Public Health Wales. Saqif, thank you so much for taking time today to discuss your journey with us. And I think it's going to be slightly different from the conversations we've had with other colleagues, but I'm very glad that you are joining us today. Thank you.
Thanks for having me, Atya. This is a great initiative.
Great. So the big question that I think is lying in a lot of our colleagues' minds who are either emerging from clinical training or early in their career is why public health, who goes into public health, what decisions do you need to take, or what factors do you take into consideration? And so I thought maybe it would be great if we could start there. Walk me through what were some of the factors that stuck in your mind and led you down this career path?
Yeah. So for me, I always wanted a career in health. I see health as like the most important thing that a person can do. Definitely my background has shaped it. My parents were both medical doctors. That definitely shaped my worldview of the importance of public health, the importance of health as a kind of area to work in. So undeniably that shaped my view. But the thing about public health and working in the health sector, there's a whole bunch of things, but the why I think is when you compare what you can do as a clinician or in other fields, you work with one patient at a time, right? And you're dealing with one patient at a time, one issue at a time. Whereas with public health, there's always this opportunity, as much as it is a long term, sometimes slow, sometimes challenging, as you'll know, process, you have the potential to have impact on such a huge scale. Like if we think about screening, if we think about vaccination, if we think about seatbelts as a public health policy, if you think about like smoking bans and all these things that we as public health has taken leadership in, if you think about the impact that's had, we're talking millions, if not billions of people. So when I think about that, and when I'm having those days when I'm a little bit, okay, got to get up, get this meeting done, you're not always sunshine and rainbows. That's what keeps me going when I'm thinking whether it's a small, boundaried project about smoking cessation in pregnant people, or whether it's something really big like COVID preparedness and response plans at the national level. All of these have significant impact on improving people's lives. So that is probably the kind of, yeah, that's probably the big thing. And obviously I had that kind of medical training and clinical background. But what made me, again, going back to, the one patient at a time versus policy at the larger level, I think it's important to recognize though that clinical medicine and those who are delivering healthcare, nurses, other workforce professionals, health workforce professionals, that's also really important. And they're doing really good public health work as well, whether we call it public health or not. It's not really a I hesitate. Why I say this is because I've had many discussions with people who are public health versus clinical medicine versus another area, but we're all actually going towards the same objective. And when you think about, I wanted to be a cardiologist for most of my undergrad training and that kind of thing, but they do incredible, like a good cardiologist will recognize that if a patient is presenting with myocardial infarction, it's not yes, it's an acute medical emergency, but they will, if they're a good cardiologist, they will think about what the root cause was, diet, lifestyle, their social environment, whether they smoked, what kind of house they were living in, what environmental pollutants they were exposed to, whether they had good social relationships, and what is that, and taking that step to understand that and providing that and seeing the person and patient and population in that holistic way, I think is the way forward. And I think there's evidence for that. And intuitively within me, I know that that's what's needed. So these are the things that attracted me to public health. And yeah, I think I'm biased, but it's the best profession in the world, bar none.
Thanks, Akif. So I think I've got a few reflections on that. The one is it is very interesting because you come from a higher income country, and a lot of the reflections from colleagues that I've spoken to thus far, obviously from developing countries, and similar thought process around maybe not necessarily the same in terms of patient load, but that sort of sense of feeling that you are seeing one patient and there's just this flood of patients that are coming. And the reason why I'm bringing this up is because I think it's a in our setting, yes, it may be due to the overcrowding and the feel that, you know, the especially if it's in a public sector environment, that you're not making a dent. But I think a lot of people in public health generally look at the way services are rendered and think, oh, we could be doing this, or we could be stemming this tide upstream. I'm glad that you brought that up, so that it's not, oh, I work in a developing country setting, and therefore I defaulted to public health, basically. And I also particularly enjoyed the point around clinical medicine and public health, because I'm not quite sure what your undergrad training was like, but I think public health training in undergrad is not taught in a way that clinicians can understand exactly the implications of needing to know about public health on their clinical practice. And it even to the point, you know, some of these discussions I've said to colleagues that go into a short course to see if you would like public health. And if you figure out that you don't particularly want to do it as a career, those skills will still augment your clinical practice. It's just about figuring out how that articulates with whatever it is you're doing. Maybe if you work in a surgical environment, you can look at, you know, outcomes, etc. Or if you're working as a general practitioner, maybe you're more steeped in the social determinants of health. So there definitely is that applicability. And as you say, there's this tension at the moment, but there needn't to be a tension.
No, definitely. I don't know if you want me to just reflect a bit back.
Okay.
Yeah, I mean, yeah, you know, you always hear that thing about like public health and the way that our medical schools, the way that our health systems are set up is that public health is often seen as like a sub branch of medicine, and that's the way it's set up. Now, obviously, it won't come as a surprise, and those that are kind of getting into public health, I think, will be of this camp. Public health in no way can be a branch of medicine, and but I don't know, somebody famous said that, you know, medicine was a branch of public health. That's also not necessarily totally true either, because it's somewhere in the middle. But the main thing is that they're both absolutely intertwined, and we don't need to. So that's and I think we're on the same page, and I think you articulated that as well. But I think it's important just to reiterate, because you know, as the next generation of public health professionals come in, we to achieve the kind of broad objectives that we want: universal health coverage, health security, healthier populations, well-being now is becoming a more important thing. It should have always been an important thing, but it's becoming more on the political agenda. When we think about these things, you're going to need the clinicians, you're going to need the, you know, allied staff. And I think in one of the initiatives we worked on together in WHO, the public health workforce development work, we acknowledge that and we try and put that in. But it's important that we orient the next generation that are coming in onto this kind of way of thinking, that, you know, it's not this zero-sum game of we need to invest in clinical medicine, so therefore some of the budget is getting taken away from preventative service or whatever the, you know, the
Mm.
so I'm kind of going on a tangent, but there is a point to this, is we have too long fought over this pie,
Mm.
like the healthcare pie, when you think from a health economics lens, and we're trying to like argue between this pie. But I would say let's be a bit more ambitious, let's be a bit more agitating of the situation, and let's make the pie bigger. And when
Mm.
people ask the question of but that means it's going to take away from defense, or that's going to take away from education. No, it's not, because we've proven from a long time, the evidence base is clear. If you spend £1 on preventative health, or
Yeah.
$1 or whatever, you get 17 back. So the you know, the maths is clear. And everybody talks about prevention, and it becomes a bit of a buzzword to the point that it loses meaning. But we need to then act upon that in this way, where you see how can the clinicians do preventative medicine, or how can other sectors detect, how can we use the education sector, how can we use policing for security. And we saw during COVID that this happened. the education sector was mobilized for health and well-being. The police were mobilized for health and well-being. The finance ministry was. So yeah. So I think yeah, that's probably the main point I want to make. There are, I don't know if you, maybe I'll turn back to you first on, you mentioned the kind of service, the overcrowded services and things. I don't know if you want me to provide a reflection on that or.
Sure, go for it. I think whatever you want to pick up on is perfectly great.
Yeah, I'm thinking about, you'd mentioned that most of the folks you've spoken to have been kind of more on the, let's say, development, but I don't know if it's South Africa, because I wouldn't class South Africa obviously as a developing country by any means. But let's say high income versus middle or upper middle or whatever the arbitrary classification is. But you probably have heard, and it comes up often in the UK media, that the NHS is under crisis. Every winter we have these pressures. So it definitely, the way health services are managed are not this quote unquote crises situation is not something that you don't see in high income countries. Obviously you know this, but for the interest of other viewers, so this is something that every health system in the world faces. You'll see US, the highest, I think is $9,000 per person. In the UK, we spend, yeah, 9,000 per person. In the UK, we spend something like 1,500. Switzerland, something like 3,000. Not sure what South Africa is, but that's how much you spend in the US. In Bangladesh, it's something like way less, like well under like $200 or something. But you still see similar issues in terms of quality, in terms of overcrowdedness, quality of care, which you mentioned as well. You still have staffing, health workforce issues. You have lack of pre-positioned stock and medical equipment and drugs and all these kinds of things. So all of these health services are facing these crises. So again, what's kind of linking it back to what I mentioned is we need to think bigger. And I think there is a school of thought, there's a movement that is going towards this way, which is that yes, we're spending more on health, but we cannot view this as something that is a burden or some kind of problem. And I know this is, I don't know if it's controversial, but at the end of the day, what do you value in a society, right? So I think we shouldn't even entertain those arguments when you've got like some of the more malicious actors within the private sector or within other the commercial determinants of health or whatever that are saying we should cut back on public services, because ultimately that is the role of government. And without that, you won't be able to have economic development, growth, whatever you want, because it comes with a health. We know this from years ago. It's about implementing it. A healthy workforce means that you can function the rest of the societal goals.
Yeah. Thanks. I think that's a very good point around health systems, whether, as you say, whether you are in a developing context or more of the developed context. At the end of the day, the burden of disease in countries is burgeoning. People are living longer, dealing with more non-communicable diseases in the face of shrinking economies. And so that's the one real issue, is that we're trying to deliver what the norm is, or what the norm was, in the face of depleted resources. But then also there's the impacts around quality of care and effectiveness and efficiency. So I think that it's a good reflection, because there's clearly there's space for public health people everywhere. It's not, again, you say, a developing world issue. There's these skills and this knowledge is needed regardless. So having said that, I think part of the reason that I really wanted to speak to you was because there was a direct request, please can we get more younger professionals that are currently training. So that was one of it. But I think, you are training in another context, which would be interesting to people, but you also were working at the WHO in Geneva and then left that position to go and pursue your further training in public health medicine. So I think maybe just if you can walk us through post, graduation, what your journey was like, then your time at the WHO, and then some of the rationale around going back into training. So, because I think for a lot of colleagues, they think it has to be this linear path, like you finish your med school and then you go and specialize. And I think your journey would probably help them to see that there are different paths to your end goal.
Absolutely. Yeah, you're spot on. I had a circuitous route to public health for sure. I think most people do. Actually, I think that's more the norm than is a linear like clinical medicine specialty or other career trajectories. So this kind of links. I'll go back a little bit to medical school because I think that shapes a lot of what then happened basically in my career. Um, and I think that was kind of the first time I became aware of public health I think we had a discipline or a subject called society and medicine or something like that, and that touched on a lot of the issues that I was feeling in my practice, as it were. Same issues coming up over and over again and that kind of thing, and seeing how can we improve services, what are the broader determinants of health. That's the first time I got engaged in that. At the same time, there was also other subjects like pharmacology, and which I took. So I did an integrated, degree in pharmacology as well. So then when I finished medical school, I knew that okay, this is not some, I was a big picture kind of thinker from an early kind of age. So I wanted to do something that wasn't necessarily one patient at a time. So when you have that kind of thinking, and when you see like the Dalgard and Whitehead model, you kind of open up. You have this light bulb moment. And then I actually went and worked in the pharmaceutical industry for a couple of years because I thought, oh, the solution is technological solutions. Let's come up with like amazing vaccines. And to be fair, there's some merit for me when I was even younger to think about those things, because ultimately, when you think about COVID and what the solution was, it was a technological solution. So credit where credit's due. So I did that, but then there's also the understanding that profit-driven approaches to health have their own issues and problems, and I became aware of that quite early, which I'm grateful for the experience and that kind of understanding. So then I decided to do a health policy master's at Edinburgh, which is like a kind of sister program to the MPH. So a lot of the similar modules, and that's what took me to WHO. I was doing a kind of I targeted that master's for that reason because it allowed for a work-based placement, and I'd heard lots of stories about things like you do your masters and then you're not really sure which direction to go, but this offered the opportunity to kind of like make sure that from masters onwards you get a continuation in employment. And for me, that linear clinical trajectory wasn't something I was interested in. So that was, again, a bit of luck, I guess. My kind of master's research was on the topic of national public health institutes, looking at things like how they managed Ebola whilst maintaining essential health services and things in contexts like Liberia. And then right after that, I think that was in 2018, 2019. And then soon after that, obviously COVID hit. And so that kind of knowledge and expertise became useful, I think, for WHO. So that's when I went over to Geneva. I did my dissertation on the National Public Health Institutes with Edinburgh. I was still at Edinburgh University, but then working in the WHO, initially in the Integrated Health Services Department, and that's what took me there. And then I spent a good 4 or 5 years there, and the learning there is unbelievable, without a doubt. You're with global experts day in day out. The impact WHO has is incredible. Within global public health, you can't think of a better organization to work at. So I think definitely that is it was an amazing opportunity. The reason for kind of taking a step back and deciding I should do my specialty training in public health is because the role of WHO is sometimes misunderstood. It's a normative agency. It gives technical advice to member states, countries, and different organizations. But in terms of its implementation capacity, particularly in high-income countries, that's not really WHO's role. Because if you think about WHO's overall budget, something like 4 billion, I'll need to check, but it's something in the billion, single figure billions. New York's General Hospital has a budget of something like 12 billion, one hospital. So so WHO, as amazing as the work that it does is, it has its limitations, and not because of anything inherent. It's because it's an organization that has a very different role to what people perceive it perhaps to be. So I got my kind of global level experience, and what I knew was a gap in my CV is national level implementation of, say, screening, say, outbreak management, surveillance, health protection at large, health improvement initiatives, how to engage with healthcare, public health, how to, how do you engage with cardiologists, primary care GPs to make them think about the preventative aspects of health. And I think the things that the specialty training gives you is, one is credibility, but two, a deep confidence in what you're then going on to say, because you know exactly, you've been there in different situations at the local level and you've experienced it. And then it gives you that ability to solve problems on a higher level. I think I'm still in the early stages, but generally speaking, and it's not that you can't get that in WHO, you certainly can. You can work with countries and everything, but the opportunity came up for me to work in the UK setting. And obviously I'm from the UK, so it was a good thing for family and other reasons, which is a really important thing that maybe we can touch on. That, I'm talking a lot about work, but certainly to be the best public health professional, or yeah, any type of professional, you have to balance that with other aspects of your life to maintain that longevity and meet the objectives that you want. So that's kind of a very whistle stop tour of my kind of journey into public health. There's a couple of other things I'm involved in, like I'm pursuing MPH and PhD whilst working, and I think these are also valuable things to do, but you have to be strategic about how you do that, because you're only limited in your time, and you need to pick when it's the right time to pick up certain skills. But if that's of interest, we can touch on it. But yeah, broadly, that's where I'm at.
Great, thank you. So I think I'm going to pick up on a few things. The I think the reflection on the master's degree having given you a sort of foot in the door, and that's not always, as you said, that's not always the case for many, because some people do a master's degree and then they are unsure as to how to translate it into either to transition out of clinical practice or transition from a field, because a master's in public health or global health doesn't necessarily mean you have to be within the health field at all. So sometimes it's that transition phase. I think that was something that I'm glad you highlighted, because many people might not be aware that there's master's programs that may lead you down a specific internship course, etc., that gives you that practical experience. And I like the reflection around not the reflection, but the sort of statement of fact around WHO and the role of WHO, because I think a lot of people think that if WHO says a country must do something, then it must be done. It's not a regulatory body by any. It's a sort of broad policy and advisory body, and how it in many countries, as you say, not so much in high income countries, but in the developing countries, low middle income countries, WHO is really a technical advisory and support, and then maybe to some extent maybe an implementation partner. But I think that distinction will really help people, because there is, as you say, there's a sort of misnomer around, and COVID brought that to the fore. People like, why didn't WHO just do this? But it's not up to WHO to do the things. The countries really have to sign on. And interestingly, I spoke to another WHO colleague as well in the South African office, and he was saying, like, the WHO is not at the mercy, but you are doing things for your member countries, and you are not there. You're not overseeing them. Basically, they are the ones that ask for things, and then WHO country officers have to assist in that manner.
Exactly.
Yeah, go
Yeah,
for it.
and and the other thing to think about is that WHO in a way is an extension of it is the countries, in the sense that what you just said, the countries come together every year to decide what WHO will do. So the 196 country member states, they decide what WHO is doing. So for lack of a better phrase, yes, it is like being at the mercy of, but it's not an independent, body that's trying to has its own agenda or anything. The agenda is set by the member states.
Yeah. And then the final, I think the point that you, and maybe we can pick up on this at the end, but I just want to say the point around doing the PhD now, and sort of the time for everything, because I think that's also, and your journey is testament to that. There is a time for everything. Not everything has to happen at the same time. And some things, you spoke about family, some things have to, give and take at certain times to allow passage of other things in your life. So I think that's a really great reflection. But before we go down there, I just wanted to ask you a little bit more about the training in Wales or in the United Kingdom, because as you said, it's a training across the different countries within the United Kingdom. And maybe if you can just share more what the training looks like, how I'm presuming, if the South African context is anything to go by, that the amount of training posts are much less than our clinical counterparts. But yeah, maybe talk more, if you could talk more about the training, about whether, is the demand as high as it is now in South Africa, and maybe just some reflection around that.
No, definitely. You're spot on. I think even pre-COVID, the demand was high, but I was looking at the latest numbers, and this is publicly available information, so folks can look it up. But I think it was something like I think there's 300 places per year in the UK for public health specialty training, public health medicine specialty training. And I think there's something like over 3,000 applications. And these are all, and you have to meet a certain criteria, like whatever the criteria is, but it's, some kind of medical or public health background to get onto the training. So it's a very high demand. But there's a bit of this is my reflection more than let's say fact, but my reflection is that there's more need than ever for public health. Maybe this is fact. There's definitely an evidence base for it, but so you've got 300 new public health specialists entering the workforce, roughly speaking. I think it's actually less. I think I'm getting the numbers wrong, but say like between 200 and 300. So, but that's not enough, essentially, because you've got so for the UK itself, you've got a population of 60 million. And yeah, by my estimation and based on the demand in terms of the public health actions that are needed, we aren't really meeting that. Now, there is like the additional public health, not the additional, but there's a broader public health workforce there that we touched on. So there's also that consideration. But with public health, you want to ultimately have a professionalized workforce, because this isn't we're dealing with the public's health. So there has to be that discussion and some regulation around who is working in public health roles, which is something probably the UK is more advanced in than other countries. For example, there's the UK Public Health Register, which is something, but not everybody registers for it. It has its own kind of logistics things that need to be worked on. The training program itself, I was touching on that it is highly competitive, and there's a series of steps that you have to take. First, you make your application sometime around, I think it's November-ish time. There's a deadline, and again, it's the Faculty of Public Health that is the main body in the UK that I would say runs or decides what is on the quote unquote syllabus, which are a series of competencies that a trainee needs to show or demonstrate with evidence over a period of 4 or 5 years, sometimes more, to then become deemed as a specialist, and then you can apply to consultant jobs, which is a senior level, essentially doctor or a public health professional working in public health. So going through the kind of application process, and it is, I believe, open to folks from overseas, as long as you meet the kind of criteria, as far as I know. But again, this will be publicly available information. So you make the application, then you get some kind of long list where you get selected to do like verbal and non-verbal reasoning. It's quite a robust kind of set of tests, and the situational judgment test. So the clinicians often do well in this because it's bread and butter. But you can get these skills through online practices. There's companies that offer these, and they are worth it. I would say if folks are thinking about applying to it. Then if you get yourself through that, then you're invited to a selection center, which used to be in person. you kind of join other candidates and you're put through a number of kind of carousel style interviews and stations that test all kinds of different things. So I think it's one of the, having done kind of private sector, pharmaceutical consultancy, that kind of thing, I think it's one of the few public sector recruitment processes which really do look at the holistic person. So I think it's good. It is challenging. There's obviously, like any kind of recruitment process, there's some limitations in terms of some people test well, some people don't. But I think it does overall. It's a good process, and you can, and if you're thinking about it, you should definitely get some practice in, and there's some like past papers and things like that that can help. Then when you get into, I don't know if you want me to touch on the training itself.
Yeah. Yes, if what the training looks like would be great as well. Yeah.
So what attracted me to it, and this is, I think it's an absolute privilege to be able to do some of this, and because I'm sort of at a kind of middle career level, and I think that it's such a privilege to be able to kind of take that step out, having done learning 5-6 years ago formally, and then being able to kind of come back and then test. Okay, I was doing X, Y, Z and WHO, and speaking to countries, working with different organizations, but then going back to the theory and then testing it in a different setting is such a invaluable experience. So I would recommend, it's part of continuing professional development really, but it's a privilege to be able to do it in such a systematic way, because like I said, the Faculty of Public Health outlines what all the broad competencies are that you need. So for me, I can check, okay, what did I do before? What do I still need to do to become this holistic public health professional? What it looks like in practice is you normally start the first year with, you've got professional examinations, which is the diplomat in Faculty of Public Health and the member of Faculty of Public Health exams. It's like the equivalent, I want to say, for the clinicians, like the MRCP Part 1, Part 2, broadly in terms of, but the content is obviously very different. What I think the benefits of it is one, you're getting tested on this holistic syllabus, and two, it gives you that professional accreditation. So when you go around speaking to different organizations, you have that credibility that yes, you know what you're talking about. So that's really good. So that's basically most of what your first year will be like. In many people who haven't done an MPH, will do it. So this is also really great for folks that have already done an MPH to consider, because you can potentially go into the second year. Then what you can do is, in my case, it's a very flexible approach in terms of what placements you then do. So a typical registrar will do, for example, I think the health protection one is the only mandatory one. So that is health protection, I'm sure folks know, but it's communicable disease and environmental protection, broadly speaking, and with probably a higher focus on communicable disease control. So you start with that, then you're highly encouraged to do a local public health placement. In the way that Wales is set up and the UK is set up, is there's equivalents of local health boards and bodies. In England, it's slightly different with local councils where public health sits, which is again a showcase of multi-sectoral engagement, which is, as we know, key in public health. So you're highly encouraged to do that for about 12 months. Your health protection placement is typically 6 months. Then you essentially have freedom once you pass your exams, to design your own placement. So you can do health improvement, you can work in healthcare, public health, you can work in academic public health, you can work in global health. Because of my previous work in WHO, I've obviously maintained connections with WHO and the work that's being done. I'm planning on, I'm going to be working with WHO's European office on a project this summer, which is again, it's such a privilege to be able to take your academic knowledge, take your theory, and then apply it immediately. But you have that flexibility to design these placements, as long as over the 5 years you're ticking off your competencies with evidence. So that's how it broadly looks.
Oh, great. Thank you. So I think a few things I just want to say. We have 65 million people in our country, and we have about maybe 3 or 4 public health posts a year that are open. So you consider yourselves very lucky. We are fighting. I'll take those stats to our health planning, workforce planners and say, look, we definitely need more. But yeah, I think similar ratios in terms of the application numbers that we get for those, few posts that are available. And it's interesting. I think the process of application seems and sort of interviewing seems quite robust. And I guess, to get through that many applicants, you do need to make sure that you are selecting the best. So something rigorous like that does make a lot of sense. I also just want to pick up on the point around professionalization. And I just want to clarify for anyone that's watching that when we talk about professionalization, it's not only for medical doctors. There's a huge workforce of public health professionals out there. And there is this move towards finding a way to professionalize these different cadres of public health professionals at different levels. And our colleagues at the WHO are working a lot on thinking this through, so that there is, again, credibility, some sort of standardization of what you expect from this professional cadre, and then, assigning job roles, remuneration and all of that comes with the professionalization. So I don't want anyone to think that when we talk about professionalization, it's only for medical doctors. There really is a move to ensure that the entire cadre of public health professionals are seen in a particular manner or professionalized in a manner that allows us to plan a workforce accordingly for different countries. So having said that, I think that's a really great reflection on the training. I just wanted to ask, is the training also a four-year training, or how long does
I
it?
think typically it's 5 years, but I think you can do it shorter or longer depending on, the main thing I think is there's probably a minimum period that is linked to the GMC, even if you're in a non-medical route or whatever, but the GMC regulates it as a whole. So there's a minimum level. I think it's 4 years is the absolute minimum, but you can, people shift to part-time and take 6, 7 years, but it's fairly flexible.
Okay, all right. Yeah, so I think it sounds quite similar in terms of South African training, where you do MPH modules to get the theory under your belt, but then you are doing experiential learning. And I think that is what I'm getting from your articulation of why you've decided to train further, is that there really is some value in actually working at that level on the ground, and understanding what it is practically when we try and implement policies or we try and make decisions. And so I think that is the real value of the specialty training, is that you actually are steeped in these real life situations.
Yeah, I mean, just an additional point on that, like public health, and I think medicine at large, and many professions, technical professions, when you can become a global expert in one area. You could be a global expert on surveillance for a specific type of influenza, but that doesn't automatically make you an expert in screening or in even another type of surveillance, for example. So I think just having that mindset for folks that are, thinking about public health, it's an important mindset that you should, if you are going in different areas, you do need to keep your skills up to date and think about how to develop those skills if you want to move into different areas. There's a lot that's translatable, of course, but that's what I think the beauty is of public health, that you can try lots of different things. And that's another reason for the attraction, I guess.
That's an excellent point, because I think public health, as with many other careers, has a broad range of areas that you can get involved in. You may come out of training knowing very well where you don't want to work, but sometimes it takes a little bit of trial and error to figure out exactly what you are gravitating towards, because again, the area is so broad. And as you say, it's all the way from outbreak response and communicable disease and public health emergencies to policy and management of health services. So there really is a niche for anyone. And even within that, different people have sort of different, you may be a broad public health specialist, but you still may have an area that you gravitate towards, and you work more in that area, still having insight into some of the other aspects of public health as well. But your statement really brought us, I think, to the next question, because you've started with the advice giving. So I'm gonna move us into that question. So I think a lot of us, and I say this frequently, so if anyone is watching the series, they probably, heard this ad nauseum by now. But, when we speak to people who are, mid-senior in their careers, it can seem very much like we all had it figured out. There was a lovely linear map that said, step A, step B, step C, and it's not really that, that's not really the reality when you are actually navigating your career. And so the last question is just around, like, what advice would you have for the next generation of public health professionals that maybe you would have found useful when you were in the initial phases of your public health journey?
Yeah, I mean, I'll maybe start with a bit of a philosophical one and then a little bit on the
Okay.
practical. Um, so I think what I wish somebody had said to me at the very beginning, do not lose sight of what we are actually meant to do and what our main objective is, which is it's not about, climbing the career ladder, essentially. It's not about, as much as it's important, it's not about the fancy degrees. It's not about, it's obviously part of it, but that's not the main objective. The main objective is for us to improve population health and make people's lives better, healthier, make people thrive as much as possible. And I think it's easy to say this on a webinar when we're in a kind of relaxed state, discussing amongst colleagues and things. But in reality, when you're in the weeds of it, when you're fighting, no, I shouldn't use the word fighting, but when you're challenged by different organizations, interests, groups, subgroups, even within the health sector, it can become challenging. But it's important to always remember why you got into it. Does it suit your personality and your values and your skill set? Because otherwise it's going to be really challenging. Because as much as I stand by public health being the greatest profession that there can be, but there's, like anything, there's challenges. So you need a bit of stamina and things that can anchor you, support you when it gets difficult. And I think public health and medicine at large is getting better. And I think with, again, a millennial, post-millennial, Gen Z, and all the rest of it, there I think there's an acknowledgement that work isn't everything, and
Yeah.
actually being able to understand that makes you more effective at your work. Because nobody wants a burnt out workforce. And making important decisions about COVID, and we saw the kind of calamities that that occurred around that. Yeah. So that's probably the kind of more slightly wishy-washy but important philosophical point. And then on a practical level, when I think about what's helpful is, I think I touched on a bit of the practical, like really try and understand yourself, what your skills and what your values are about. What are you good at? What do you enjoy doing on a day-to-day basis? And there will be something within public health, but it's good to have that thinking and pick up that toolkit as you progress from junior to middle, and or if you go back to different roles or whatever, you can do that and pick those skills up. Um, I think you will have definitely, Ati, I know you know about this and you will have touched on this, I'm sure, before, but I will repeat it because it's important. Mentors and peer support is so important. I think I would know there's no way that I would be doing what I'm doing if it wasn't for the help of, including yourself, Atia. Like, we've had so many conversations and things that have helped me shape my view and bounce ideas off each other, and really value and understand the importance of these and maintain those when possible. Um, the other numerous mentors at Edinburgh, WHO, Public Health Wales, all over different organisations. Without them, I don't think you can get very far. Um, and then the point on peer support, sometimes your seniors are great, but you can't have candid, really straightforward conversations. That's the reality of how it is. And you'll feel less alone as well. And especially in this kind of post-COVID online virtual world, you're sometimes working, public health is quite different from clinical medicine and other jobs. Often you're on Zoom call after Zoom call after Zoom call. Not all days are like this, but some days can be like that. And that it helps just to we're social beings. You need some, call it validation or call it reassurance, or just a checking in point that the trajectory you're taking is one that is makes sense, is important. And you will also learn. It depends what your learning style is like, but there's a huge amount of knowledge required to do well
Mm,
in public health. It's such a huge area. You need, I think you need basically knowledge about other sectors, encyclopedic knowledge sometimes of other sectors. You need to understand clinical medicine to some extent. You need to understand how health services are organized. You need to understand health economics, and
yeah.
yeah, so many psychology, behavioral science. So to it's like almost like going through medical school, and the way that most people manage to consolidate that learning and understanding of things is by speaking to others and stories, learning about just those discussions are very important. So I think there are a number of kind of key things. I'm trying to think. Uh, yeah, I mean, I think that's the broad brushstrokes. There's probably a lot of things that I would have liked to share, but yeah, that's the first things that come to mind.
Thanks, Akif. I have to say, I really, really enjoyed your philosophical point. And I think the reason why is because throughout these conversations, we've just tried to articulate to people that public health isn't sort of the default to not wanting to do clinical medicine. And you it can be just as difficult as pursuing clinical medicine, especially if you don't enjoy it. So if you are going into it for whatever reason, aside from really having an interest and a passion for it, it can then sort of weigh you down and get frustrating. And so I think the point around, thinking about why, and I know you spoke about why somebody is doing public health, but taking a step back and just thinking about why it is that you want to do what you are aiming to do is a really great point. And especially since a lot of us go into university degrees, sometimes not really understanding what that actually means for you in your career. And so if you can, taking a breath and just trying to figure out what you really are aiming to do and how you are aiming to contribute to this world in whichever way, it really does help. And I think your other practical points are just as valuable around mentorship and peer support and work-life balance. I think even though we are having these career conversations, your career doesn't exist in a vacuum. And so having those support structures or being cognizant of how one decision would affect other aspects of your life is very important. So thank you for that. And I think colleagues who are watching will find that quite reassuring, that we need not have it all figured out, but you can take some time to just consider all of these aspects. So I have covered sort of my agenda for this conversation. Thank you. I'm just going to ask you if there's any last reflections you have before we close off.
Oh, thanks, Atia. I think that last point around that if you think about public health as a way, it's like a vocation, isn't it? It is something that is very consuming. It's not like a vocation, it is a vocation. But the way that the heart of public health is thinking about things holistically, not just in a narrow tunnel visioned way. It's about these buzzwords that do have meaning, like integration, wider determinants, looking at things outside of your immediate vicinity. So I think that links to the last point that you made, which I think is really important, that you need to also apply that same thinking and kindness to yourself when you're going through and to your colleagues. And because the challenges that we're facing, without a doubt, are huge. But to end on a slightly positive note, public health has had a whole series of successes as well. It's not all doom and gloom. And it's by taking this kind of broader approach, by taking this kind of, I think, applying some of those principles to yourself is how you can have that longevity and sustained approach. And also that understanding and appreciation that, okay, some of the things that I'm going to do will have impact. Not everything will, but you're leaving this world in a slightly better place in your own limited capacity than you found it. And that, I think, is at the heart of most people's kind of objectives. So, and I think public health really allows that. So yeah, that'll be my final remark.
Thank you. That was a really lovely reflection. So I'm not going to even add to that. We will leave it with those words from Saqif. So Saqif, thank you so much for spending time with me today. I really appreciate it. And I'm sure, your journey, the reflections that you've had will, help someone who is watching out there to, just think through, as you say, a more holistic picture of their career and help them potentially, and hopefully make better decisions regarding their career, whether it's in public health or not. So thank you so much. I really appreciate it.
Thanks so much for having me.